I'm Abby Gray, and I had a torn meniscus about a year ago in my right knee. Unexpectedly, all of a sudden, my knee started to click and give out randomly. When I first met Dr. Farrell, I knew right away we were going to get along great. He understood that I am a very active person and can't stand not moving, and I move quickly, and I have two small children, and he was, bedside manner is fantastic, very friendly, very engaging, felt like he really wanted to help me in particular with my particular problem and get me back to active as quickly as possible.
So Abby presented to me a few weeks out from an injury to her right knee where she felt a pop in the knee and then a sharp pain. And since that time she's had what she describes as a clicking or a catching sensation in her knee that really bothers her. And really anytime she's on her feet and she pivots or twists, she has that sensation, and it's really affecting her and limiting what she can do. So examined her knee. Her physical exam was very concerning for a tear of the meniscus. So looking at the model of the knee, what's the meniscus? So inside the knee joint, we look at a model of the knee here. The knee is made up of the patella, the kneecap, the femur is the thigh bone, and then the tibia is the shin bone. And between those two bones, you have two semicircular or C-shaped structures if you look at them from the top down. If you look at them from the side, they look like a triangle with the point of the triangle in the center of the knee and this wide parts on the outside. And the meniscus essentially works as a shock absorber. And unfortunately, as we get older, the collagen bundles in the meniscus get disorganized to some degree, and it becomes easier and easier to tear the meniscus with something as simple as twisting or pivoting or squatting to pick something up. And so based on her physical exam and her history, which was quite concerning, we ordered an MRI. And the MRI did confirm a tear of the medial meniscus, which is that meniscus on the inside part of the knee. At that point, we discussed treatment options for her. The timing wasn't quite right for her to have surgery. She had some other things going on. So we started off with a cortisone injection and some activity modification and some exercises for a home exercise program. We started with that management, but unfortunately she continued to have these mechanical symptoms, the clicking and the catching and a sharp pain associated with those. And that brought her to consider a surgical intervention.
The explanation of what was going to happen and how my recovery was going to go and the discomfort I was going to have, he really laid it out so clearly that it made me feel so much better. In addition, I was nervous the day of the surgery, and the way he came and checked in, and he's just so easy to interact with that I felt like he was paying attention to me as a person. He knew I was nervous. And I felt very reassured throughout the stages, but even the day of the surgery, just from talking to him.
And the surgery for this problem is minimally invasive. It's called an arthroscopy, where we make just two little small incisions in the very front of the knee, poke holes if you will, very small. And we put a camera in the knee and we use instrumentation. And basically what we do is we in most settings, we clean out the torn tissue, which is not functional, and we leave the good tissue behind, and that's called a partial meniscectomy. In a certain number of cases, we do repair the tears. The issue with the meniscus is if you look at the blood supply to the meniscus, only the outer 10 to 20% of the structure has a blood supply. And what that means is that tears that are in the inner 2/3 don't have a good capacity to heal, so they typically don't get better on their own, and even if you repair them, they don't always heal. And it's really a unique tear pattern that is repairable. So we discussed surgery, and Abby elected to move forward with that. She did have an arthroscopy with a partial meniscectomy, It's about a 20-minute procedure. It's very quick. It's outpatient. You go home afterwards. You're typically on crutches for just a day or two, and then you're up and walking. You can move your knee as much as you want. You can put as much weight on it as you want. You're not going to damage anything or tear anything. It's just a matter of soreness that you're dealing with. And we usually see patients back in the office in a week or so to get the 2 stitches out. And we do physical therapy to work on range of motion and strengthening. And all told, it's probably a 4 to 6 week process before it's water under the bridge for you. Patients typically do very, very well with the right indications. And Abby did very, very well.
Since the surgery, I recovered really quickly. I did all the exercises and stretches I was told to do and got back on my feet very quickly. And have had no pain or problems with that knee since. I would absolutely recommend Dr. Farrell to anyone needing surgery. He was a phenomenal doctor to deal with from beginning to end, and was able to see me as quickly as possible and worked in surgery as quickly as we could get it done so that I could be back to mobile. And lots of checking in. I just felt very, very well attended to as a patient, and I would absolutely recommend him.